co-chair of the Care Coordination Task Force with Julie Shills within the PCPCC. I would like to welcome everyone to our webcast entitled Care Coordination, Lessons Learned from UNC Chapel Hill, presented by Rob Malone and Jennifer Lord. Rob is currently Vice President of UNC's Healthcare Practice Quality Innovation Center, where he works with physicians and other healthcare system providers in ambulatory care service areas to improve patient experience and outcomes, operational processes, and business performance. Rob has held several positions within the healthcare system School of Medicine, including redesign change manager and faculty for UNC Patient Access and Efficiency Initiative, as well as director of the UNC Center for Excellence in Chronic Illness Care. Also presenting with Rob is Jennifer Lord. Jennifer is Medical Home Project Manager for UNC Healthcare. As part of Practice Quality and Innovation Team, Jennifer works with UNC's outpatient clinics to implement operational processes that are guided by joint principles of the patient-centered medical home and optimize meaningful use of health information technology. Jennifer has created several distinct programs offering workshops and tools to help patients be informed, prepared, empowered in their decisions with healthcare professionals to make better decisions in the care and treatment they receive and to participate effectively in their healthcare. It's an honor to have both Jennifer and Rob here today. All lines have been placed on mute to prevent any background noise. Today's presentation will last approximately 45 minutes, and there will be time available at the end for Q&A after the presentation using the electronic question area in the bottom portion of the GoToWebinar controls. It is my pleasure to introduce to you Jennifer Lord and Rob Malone.
Good morning. Thank you, Guy. I'm also a member of the Care Coordination Task Force with PCPCC, and Julie had asked me if there was anything interesting going on at UNC in the area of care coordination, and we actually have quite a number of things going on at UNC. The first one that came to mind was the innovative work that's been done in internal medicine, and as we were going through the content, it became clear that this was a presentation in itself. It's my hope that we'll be presenting in the future on other areas of the UNC healthcare system, specifically our Family Medicine Center and our Pediatric General Clinic. But for today, I'm basically going to turn it over to Rob because he was involved in creating the Enhanced Care Disease Management Program. So I'll turn it over to Rob.
Good morning, everyone. I think today what we're going to do is, it's not a very data-heavy presentation or discussion. There are a few graphs, but most of this is really a conversation, and I'm going to tell a story over the past, summarizing what we've done over the past 10 years or so. And at the end, I think there'll be a few slides that will generate quite a few questions, and I think that's going to be the most interesting part, to be honest. So we'll take a few minutes to go through the slides and then have a discussion at the end. Jennifer's contact information. Jennifer's contact information is listed in the second slide. She's available after this if there are any follow-up questions. So let me start with a brief history, and then we'll go through and provide some details. So basically, our practice in the late 90s was a traditional academic practice. Very busy, very fractionated, hard-working, very smart docs providing really good care, to be honest. But there was a lack of continuity due to, part-time providers functioning in an academic practice. In the late 90s, we added 2 mid-level providers. I was one of them. We pretty much worked with a laptop on a little rolly cart in the hallway of a large practice and tried to help patients any way we could, and that's how we started. In the early 2000s, that's when we really developed a population care mentality, and we had the capability to take care of a population of patients. Our inherent systems at UNC at the time could not provide this service. We had to develop our own registry system. We developed evidence-based algorithms along with our faculty. We really focused on proof of concept, and there's a rigorous evaluation that we went through for several of our programs, and we have a few published papers on those. In the mid-2000s is when we really started focusing on our team, what the right components of that team is. We solidified what we call our care assistants, which we'll talk about later. And we really focused on integrating what we had done in silos within the practice throughout the practice. I'll explain that a little bit. In the late 2000s, that's when we really started focusing on spreading the model for improvement throughout the practice, focusing on efficiency, integration, and we really added a lot more decision support and some more extenders, and I'll show you these in later slides. So the care philosophy of the practice today is pretty unique. Like I said, we used to do these things in silos, but across the practice now, here's what you would hear coming from our faculty and our division. Key elements include patient engagement, universal precautions for low literacy, multidisciplinary teams, population management, evidence-based algorithms, CQI, proactive nature of managing all patients. We've got a few accreditations. We could have more, but we've decided to spend our time and our resources in other areas lately, but we've got 3 important ones that we wanted to attain. 2 NCQA recognitions, one is a medical home, and then our diabetes classes are ADA recognized. I have a link here for results that we've summarized in a PDF document for you that's available on the internet if you want more information there. Today, here's what our practice looks like. A large academic practice with a multidisciplinary team. So the practice staff, I have them separated here for a reason that'll become apparent later, but we have 125 physicians. They're all part-time. Of these 125, that is roughly the equivalent of 15 full-time physicians within this practice. 12 nurses, you see the breakdown there. The fact that we only have 1 RN out of 12 nurses is pretty unique, I believe. 18 admin staff, a couple dedicated to making sure the referral and ancillary process work well. Our program staff is quite large. Remember, this started with 2 10 years ago, and we can walk through how we got to where we are today later. But it's a large practice, as you can see. So if you look at our practice patients, here's how it breaks down. And I think this is pretty similar to any other primary care setting. I don't think there are any surprises here. And you'll see that most of our programs we have in place and most of the care we provide target most of these diagnoses. Our patients' key characteristics, this was a part of our PCMH application, and we still use it to make decisions today. But I think that as far as gender and age and ethnicity, very similar to other academic center settings like ours. You can see the breakdown of education for our patients are really across the board. Typically lower socioeconomic status than most places, I believe. The lower right-hand corner, we have a summary of some work we've done around technology use of our patients, which has helped drive a lot of our decisions we've made with resources, who to add to our teams, how to deploy resources for patients. So I think this is helpful information. And we'll talk more about that in a bit. Our patients and where they come from. The little spinning yellow star in the middle is Chapel Hill. We're not too happy today after our loss to Duke last night. They're about 8 miles north of that star. But we made it in today nonetheless. So what's interesting here is you also have to, it's important to know that we're a practice full of part-time providers, but it's also important to know that our average patient travels greater than 30 miles to get to our practice for primary care. That really changes how you can deliver care to patients. So you can see we deliver care to patients from Murphy, which is in the mountains, to Manio, which is on the Outer Banks. So that definitely changes our decisions. Our current enhanced care programs, I have that in quotes because that's really what we call our disease management programs. Our active management programs, there are 5 of them at this point. What I mean by that is these are programs anchored by a mid-level provider or an extender that is backed up by a registry that includes decision support, data rigorous. We have control charts where we monitor our outcomes. We have basically support in place to drive care for patients that have any of these disease states. Decision support is an interesting one we'll talk about in a minute. We treat it almost like a disease state of its own, but it seems kind of odd in that list, I know. Surveillance and prompting, we have 3 disease states that we currently, or preventative medicine issues that we surveil and do a good job of monitoring. The question mark for transitions is because that's the one we're developing right now. That's obviously going to be more and more important to us in the future. And it will actually probably flip over into the active management program because we feel like we need to dedicate resources just to that task. So basically all of these programs are grounded in quality improvement efforts. The people that run these programs, the people that are accountable to our outcomes, have a training background in quality improvement, and basically we have to demonstrate our efficacy. So we have some more information available about some of these programs on the internet as well. If you looked at our patients, so basically our argument would be that today, as of today, every patient receives enhanced care. If you look at fiscal year 2010, we had 41,000 visits. The majority of those are returns, as you would see in primary care. So if you look at the patients, there are 10,000 unique active patients. So patients that have been seen within the last 2 years in our practice we consider active. Of those 10,000, all of them are covered in some way. So almost 2,500 are in our diabetes program. Almost 700 are covered by our anticoagulation program or our chronic pain program. The other 7,000 are in some sort of surveillance. So we didn't get there overnight, that's for sure. It was only recently that the last 2/3 of our patients were actually covered by some sort of program, and that's because we decided to make sure we were doing a better job of surveillance in prevention, disease prevention. But what we learned in those early years is what I want to talk about going forward. We basically learned, and I think others, this is clear to others as well, I'm sure, that have been doing this for a while, but a successful program, we must have consensus-backed, evidence-based algorithms that are backed by consensus of the providers in the practice. A multidisciplinary team to anchor these programs, a philosophy that promotes real care coordination and management, a registry with disease support for proactive care, and reporting. Transparency is key. I know we've all talked about this before. Persistence and leadership are key. I can tell you over the past 10 years it wasn't easy to get where we were at. There were 3 periods of loss of funding, 2 more additional episodes that almost derailed the whole program. If it weren't for leadership in place to make sure it happened, we wouldn't be doing this care today. Appropriately designed interventions or systems can overcome patient vulnerability. That's what we've demonstrated with some of our evaluations we've done to date, is that we can fix gaps that are within the healthcare system for the most vulnerable of patients, and the care we provide, we feel like, does a good job of doing that. And then lastly, there's the continual evolution. Change is necessary, and we want to look at it as a positive, as an opportunity to continue to get better. And we really wish that earlier on we would have embraced rapid cycle change in the model for improvement. That's probably been a focus of ours for the last 5 years and should have been a focus from the first day. So what we're going to do is, in the next few slides, really talk about the red areas, okay? So we're going to go through these bit by bit. So lessons learned. A registry and decision support for proactive care. Let's talk about that a little bit. So we have an advanced and integrated registry. So what I mean by that is we spent a lot of time and effort and money, frankly, on developing our registry systems. These registry systems are anchored by something we call Cypher, which we developed. It's not unique to this type of work. I'm sure there are many others that do it, including our Family Medicine Center, who has their own program in place overlaying UNC's resources to do similar type of work. But what I can tell you is that what we've been able to do is integrate what the healthcare system supports on this left-hand side with our system, which is on the outside, to deliver what we think is planned, proactive, high-quality care. And we believe it's also very efficient, and I'll show you some of the tools we use to do that. So basically, we can have, if we were just using our current IS resources, we would not be able to do many of the things on the right-hand side, which is patient-entered data. We wouldn't be able to really disseminate data across our practice. We wouldn't have the ability to do reports and overlay decision support to what we do. And data entry would be problematic because current IS resources mandate that we use what is our current electronic medical record to enter all records, all data into our electronic medical record. Our system allows us to do that separately. So like I said, it's probably not unique to what many of you are doing, but what we know is that we are shifting more and more towards complete integration of these two systems, and we know that we have to completely replace this outside system with a healthcare system-wide resource. That's the road we're going down now. Lessons learned, consistent, evidence-based algorithms backed by consensus. So what do I mean? Here's one example on the right, and there's several that we have posted on the internet and are available at the link you see at the bottom of the page. The image on the right is of a standing order we have in place for metformin titration. This is probably not the most unique or most important algorithm or example that we have to date, but I put this one over here because, I don't know if you can see, it was last updated in July 2005, but the original was from 1999, and this was our first evidence-based algorithm that we had in place that allowed non-physician staff to manage patients with diabetes through standing order. So that's why I have this particular example up there. So basically what we've committed to is to say that basically we want to describe what it is we want to have done. We want to define what high-quality care would be, determine what measures would be to track and assure we are providing that high-quality care that we want to provide. And we want to basically, where evidence may not exist in the standardizing an approach to care, we want to arrive at some type of consensus to say, here is what we want to deliver, here's the model, here's the care we want to deliver in internal medicine. So the argument would be that without these algorithms in place, you really can't tell your team what to do, how to do it, when to do it. That's the level of detail that we're getting down to when we're trying to develop these algorithms. So our goal is to standardize care, decrease variation, set expectations for leadership, but also for those that deliver the care. We want to facilitate reporting and improvement. So basically, if we don't know what the quality standard is, it's hard to report on that. And we use these to optimize our care team. So basically, if our physicians determine that they want a particular service delivered, then myself and others will decide, well, how can we deliver that service and meet that expectation within the budget that we have with the people that we have in place. So I think these are often undervalued, but very important. Lessons learned, further lessons learned. A multidisciplinary team and care coordination. So let me talk to you about one of the members of our team that I think is probably been one of the more important things we've done over the past 10 years. We have a position in our practice called a care assistant. They're called a care assistant because it was difficult to find another name that we could use that didn't create some other issues or some misunderstandings. For example, patient navigator, case manager, case care coordinator, those types of names often created the thought that these were nurses providing this care, and they are not. So basically, our multidisciplinary programs are anchored by what we call care assistants. These are graduates, recent graduates who are considering application to medical school, social work, or PA programs. They're very motivated, want to take a year or two to do this type of work. These are full-time employees who participate in direct patient care, program support, and do our quality improvement work on a large part. Right now we have care assistants in our diabetes program, our chronic pain program. This chronic pain program care assistant also supports our depression program and the social worker who manages that. And we are experimenting with one of these physicians within our transitions, our developing transitions program. For us, we're in an ideal setting to do this because we have 3 very good universities within a 20-mile radius. We have a great medical school, a leading public health school, so we get a great pool of students to pull, recent graduates to pull from to do this. There's more information available on the internet about these, what the application process is like, that kind of thing. They're available by the link you see at the bottom of the page. So a little bit more about them. So let's say the care assistant's role in our diabetes program, for example. Their job is to implement our enhanced care evidence-based algorithms to direct patient care. They came out of our initial discussions around, well, there's a theory within primary care and chronic illness care around inertia, right? Oftentimes things just don't happen because lots of other problems get in the way in any one particular visit. So basically they keep nudging everyone along, keeping their eye on the prize, right? They know what the end state should look like, and their job is to figure out how to get there. And if a patient, for example, may not be indicated for a therapy, like, say, a diabetes patient with a high cholesterol that's intolerant of multiple statins, for example, they will make sure that that's documented in the medical record in such a way that we will avoid further prompting in the future. But they will make sure that these are true issues for that patient before doing so. So their job is to keep things going. And they do this through regular phone calls to patients. They reinforce what the providers say. They're usually present during a lot of key encounters with the primary care provider. They really cater to the residents. If we know there's a high-risk patient coming in today with the resident, and this patient seems to be struggling based on our phone call encounters, a care assistant will be in that visit or talk to that resident before that visit to make sure issues are addressed. They really educate, instruct. They do simple tasks like glucometers and injections, and they become really good at it. They assess adherence and progress towards action plans and goals. They do minimal symptom assessment. What I mean by that is they might look for a hypoglycemia, but they don't get into other disease states. That's not really their job. They're really into patient-oriented problem solving. Just talk to the patient, see how they're doing, see what the concerns are, try to develop that relationship. Medication management with extender support. So basically, they don't change anything unless a PA, NP, or pharmacist directs them to do so. Depression screening and follow-up, smoking cessation counseling at a minimum level. So that's what a care assistant today in our diabetes program is like. I have more examples later that if we have time I will show you. Lessons learned. Proactive care and evolution is necessary. So let's talk about that a little bit. So in the last 2 years, we changed directions on what we were doing. Prior to that time, we spent a lot of effort, and I would say the majority of our effort, probably 3/4 of our effort, on in-clinic encounters. The in-clinic encounters were for our program support staff, like care assistants and mid-level providers, were very inefficient. So what I mean by that would be, imagine, it's almost like recruiting for studies in an academic practice. Care assistants want to find a patient who's at risk or not achieving their goals, who is seeing a resident in clinic for a routine visit. That 15-minute encounter and conversation with the resident and the patient might take an hour and a half because of waiting in a hallway for a patient to be in a room, trying to find the resident in between their process of seeing the patient, getting the history, precepting with the preceptor. You can imagine is very inefficient. So what we did 2 years ago is we thought, well, we've got to become more efficient because our resources are dwindling. We have to use them more wisely. So we started looking into something that we hadn't really evaluated before, which was, what can we do before the visit? What is the ability, what capability do our patients have to respond to us on the internet? And what do they want to do? Because it was really the thought of our practice that, one, our patients wouldn't have access to the internet. Two, they're older, poor, and less educated, and very few of them would actually use the internet or email. So we never really developed this idea. So what we did was we assessed about 200 of our patients and really blew all of those stereotypes, you may want to call them, out of the water. What we found was that over 65% of our patients, in a pretty rigorous assessment, we did a good job of assessing our patients to make sure we got a good sample, but 65% of our patients were internet users, 65% were email users, and they classified themselves as regular users. So we were blown away by that. And when you looked at these folks and asked them specific questions of what would you be interested in doing, you really see that even non-users are interested because they actually have surrogates that do some of this work for them. But people want more information, health information, but they want it from their practice, from their doctor. They don't want to go to WebMD to get it. That's what that question was. They want to ask questions between visits. They want to get messages from us. They want to get reminders from us. They want to be able to provide information about their medical problems before a visit. They were interested, but it wasn't as significant to them to develop some type of social networking support group with other patients in our practice. But some are interested in that idea. So from this information, we kind of changed course 2 years ago and started focusing more on efficiency and using pre-clinic encounters by telephone or email and post-clinic visit encounters by telephone or email. And so just to give you a little information about that is what we do is we provide both surveys and education or patient decision support driven by information technology and some of the same decision support we use to drive care within the office visit. So basically, algorithms drive survey delivery. We identify patients through diagnosis codes, through history, through labs, through vitals, demographics, and use common techniques of branching logic to make sure patients get the right questions, right? And then we want to determine if they're eligible for further intervention. And that would, data from patients would drive patient-specific decision aid delivery. Decision aids are educational videos, for lack of a better word. And it would also then drive point-of-care service at the time of the visit. So the next 3 shots are just examples of what I'm talking about, and this is an older version. The newer version's trimmed down a lot because we went through our literacy work and focus groups and whatnot, but the idea is the same. A patient comes online to a secure site. They're told what they need to do today, which is answer a certain subset of questions, and then they're pointed to a decision aid, like this one is from the Foundation for Informed Medical Decision Making, Living Better with Chronic Pain, for example. So we will deliver questions based on data we have on file. We'll deliver videos that we think they may find useful, and we'll find out from them after viewing the videos how their thoughts about their care may have changed and if they in fact did find it useful. So basically, here's a survey question example. We have this in 2 formats, one by touchscreen and 2 by internet, which you use your mouse to answer the question. So we've tested this in our patient population, and that's how we came up with the format you see in front of you. The patient day would then end in a decision support aid, like I said before. Here's an example. So we'll know how much you watched, when you stopped it, what you watched, and we'll report that into the medical record. What you see here is a draft of one of the reports that we deliver to the electronic medical record. So basically, a patient would be prompted several days before their visit with their primary care provider. They'll get an email. It'll say, go to this link, answer these questions. They answer the questions. They're delivered a patient-specific video. They watch the video or not. Whatever they do is summarized in a report that then is delivered to the electronic medical record so the provider sees this at the time of their visit. The provider's note is addended to this, I guess is a better word. So basically, it's different from this now. It includes 1, a patient agenda, 2, what the findings were, what the problem areas were, and then what videos or decision aids they are eligible for. This is still a work in progress. We have a long way to go with this, but we think we're headed down the right track. Because once we do know that patients want this service, and 2, they want to know that their provider gets their answers and their provider does something about them. That's been the thing that's delayed our development the most, I believe. Lessons learned regarding our multidisciplinary team and case coordination. So let me show you something else. So this is what we call our visit planner. This is version 5. This one came out in September 2010, what you see in front of you now. This piece of paper was introduced in 2008. It's a piece of paper generated by our external registry, so separate from our electronic medical record, but it uses data that's in our record, like lab data, that kind of thing. The idea is that we wanted, like I said, to become more efficient in our visits, use more people within the clinic, use all staff, not just our program staff. We couldn't touch every patient in our practice if we continued down this road of using a siloed approach. So basically, this document's been pivotal to our planned care approach. So there are specific prompts to the patient based on data. We coordinate and identify team roles. So through the visit, there's a roadmap of what needs to be done. You'll see there's a front desk section, there's a nurse section, there's a provider section. Prompts may change, the details may change, but the format of the document stays the same. It's a scannable document, so we do have some rules to abide by, and we had to train people how to use this. But basically, the idea is to spread interventions to larger teams to improve care and make sure patients have access to all the services that they need. Details are available on the internet from the link below. So let's talk about the front desk prompts. Our front desk has been critical in our success to a great degree because I can tell you that whatever we ask the front desk to do, as long as we engage them in design of that process and let them participate in choosing what their prompts are, they're going to do it. And they do it pretty much 90% of the time, usually. So front desk, so here's what the top of their form would look like. So they document late arrivals. They are also prompted whether or not to order certain labs by standing order. So this patient is a diabetes patient, and through our algorithms, we're determining they need a point-of-care A1C and they need lipids. So at registration, at check-in, the front desk would check off whether they ordered these and complied by the recommendation or not, or if they did not, what the reason may be. Patient goes to our point-of-care lab and then goes to the provider. Provider has results for the visit when the visit starts. So you can see, if you could take this back a little further, you'd see that we did this about 60% of the time initially, and then after working through our quality improvement process, we're hovering around our goal of 90% all the time. We're not going to exceed our goal, is our thought, because sometimes there are reasons like the lab would be backed up, and to make sure we don't halt efficient flow through the practice, we do allow the front desk to opt out of testing, and that's usually why there are some times we're not exceeding our goal. So they do a great job, and they're motivated to do it. They like to see these lines at this goal. Nursing prompts. So we cut out an example of the nursing section. So in the background, you see nursing staff responsibilities where there are no prompts indicated today. I think there are about 20 different items that could be prompted for a patient for a nurse to do. More and more often now we're seeing where nurses have addressed all those prompts that we've created to date. So this would be a good visit for a nurse. What you see here on the right, the nurse would be busy. This is you know, we've had to change the mentality of your role is not patient throughput and rooming patients. It's patient assessment, patient engagement, and now, you know, administering vaccines by standing order, doing things that they were trained to do and want to do, frankly. So you can see these are 3 different prompts that we have in place now out of the 20 or so. They can opt out as well. They don't do it very often. But you can see, again, they would start, if we took this back further, around 60% of the time completing prompts. But you can see how well they do in addressing some of these issues, anywhere from domestic violence to depression to smoking. Some of these are easy to address. Others, like depression, are very complex and took a lot of work. You can see that through the run chart. Providers, same thing. In the provider section, you can see where no prompts are indicated to where up to 3 prompts can be pushed to them. And this has been very interesting and taken a lot of work. But you can see provider prompts, provider response to prompts is variable, which I think is to be expected. And we're actually okay with that, because what we've done is we've shifted all the work. So we've looked at each position and said, what's waste? Let's cut that. Then we've said, okay, what could front desk staff do that a nurse used to do? What can a nurse do that a physician used to do? And then now what can the physician do that they didn't have time to do before? And that's really the mentality. So we're actually proud of the fact, I'm sorry, let me get that we're hovering near our goal of 80% for most of these prompts now. And these are just a few that we've selected to show you. There are other examples of quality reports that are out there. These are our diabetes reports. Our next step is something we're really looking forward to. We're going to explore some alternative care delivery models. Blue Cross Blue Shield of North Carolina is our most significant payer in our healthcare system. They're the biggest insurer in our state. We've entered a relationship with them where we're going to launch a novel patient-centered practice. So the idea is going to be that, like Jennifer said, I'm giving you the background for one of our practices that does a good job in patient-centered care. But we want to learn from all the practices and take the best practices and apply in one place. So this will be a unique venture and something I'm really looking forward to, and will be, from the very beginning, the place will be built. We will recruit and hire people that want to provide this kind of care and don't want to provide this kind of care in any other way. And I think that it's going to be a great place to work and be seen as a patient. So more to come about that. What's our time check? Okay, we have 10. I have about 5 more minutes, and I can go through these slides, and then we can open the questions. But let me give you an example of a diabetes of the diabetes program, and we have about 6 slides that won't take long. But the diabetes services we provide, on top of what I showed you before with the care assistant, is education, individual sessions, group classes, medication education, and adjustment. We really focus a lot on insulin. Glucometers, we look at practical, efficient use of monitoring, that kind of thing. We have a retinal camera in our practice to address screening, and we really do a lot of follow-up outside of practice now. This is the majority of care now is provided by phone or by email to patients outside of visits by our diabetes program. Case management, so we have care assistants that are assigned to groups of patients, so there's a personalized touch. There's one phone number to call or reach your personal care assistant. Then there's a sense of ownership and accountability to that patient panel. This has worked well for us. You know, patients that may need extra help, I'll show you an example of this, or what that would look like. These patients are also worked into in-clinic encounters with nurse practitioner CDE, pharmacist CDE, or a dietitian. They're all a part of the team as well. So if you look at our diabetes patients, there are about 2,500 patients that currently have diabetes. They're broken down by alphabet now just for our sanity. So each care assistant has a patient panel, and they're broken down into risk zones. Green, they're doing well. They're hitting all their goals. Yellow, pretty much they're hitting half their goals probably, or 3 out of 4 of their goals. Red zone, these people are failing. The calculations are based on many of the things you see below, like A1C, blood pressure, key medication use, depression, smoking assessment. There are other things like their visit history, their likelihood of participating in their care, that kind of thing are calculated in that risk zone. So basically, this is another example of an algorithm, and this is a part of a larger algorithm, but everybody's broken down into risk zones, high, medium, low, or red, yellow, green. And there's an ideal path. We've defined what the number of visits with an extender or mid-level would look like. We've defined who needs to go to a class. We've defined what would constitute a call or not. So basically, let's look at a high-risk patient. So basically, this patient is going to get, at minimum, there are other things that will trigger encounters, but at minimum, they're going to get a call 2 weeks before a visit, a care assistant in clinic. They're going to get a call on the same day if a no-show, a call 2 weeks after the visit, and they're going to get visit coordination for other services. So that means the dietitian, the class, the nurse practitioner, that kind of thing, our whole package. So in minimum, here's what you see. So the model would look like this: a pre-clinic call, in-clinic visit, post-clinic call. So pre-clinic call, it would be, basically things that would be addressed during the call are patients not checking their blood sugar according to recommendations or not following the action plan. What can we do to get them to do those things before the visit so that we make the most out of the visit? We would look for things like, is their eye exam out of date? Do we need to take that primary care provider visit that's scheduled and couple it with a retinal camera visit? What's their likelihood of no-showing? Work through problem solving to make sure they have transportation and whatnot. So we make sure they bring meters, they have testing at the right time, they confirm that they're going to come, those kind of things. In clinic, same kind of thing. We're going to work with the provider to make sure we address all the outstanding issues that we've identified and make sure the patient knows that there's a real person behind the voice on the telephone. We think that's really important. Post-clinic, we're going to follow up the plan from the provider. We're going to follow up with an assessment and history on the telephone and address gaps, because we know that 3 out of 4 phone calls, we're usually doing something of significance, whether it's adjusting a medicine, identifying a patient who did not start a medicine or did not fill a medicine and having them do so. Many things like that happen after the visit. So that's what a flow may look like for a patient. Those are all the slides that I have planned to show you today. And I think at this time we'd like to address some questions.
Great. Thank you, Rob. And Jennifer, that was fantastic. I would like to mention that today's slides will be available along with recording on the PCPCC webinar page, which is located at ptpcc.net/media. At this time, we will begin to take questions. You'll see an electronic question area in the bottom portion of the GoToWebinar controls. And Jennifer will be taking those in the order received.
We have none at this time, so if there are people that want to either text or ask on the phone, that's fine.
Okay, we are getting some questions in. Jennifer, are you able to see those?
I am not seeing any questions. I sent you an email. I'm not sure why.
Okay, I'll just go ahead and go through. We do have time for questions, so we'll just take them in the order received. First question is, how do you assign patients with multiple conditions, for example, chronic pain, diabetes, and heart disease?
That's a good question. So the patient's still the center of the focus. So we use the different conditions to determine best practice, but the conditions don't drive. I'm trying to let me think. That's a good question. We don't let the conditions drive every encounter outside of the patient. So basically, each patient encounter is unique, and in that encounter, we make sure that we don't just focus on diabetes, but we take a holistic approach. For example, I see diabetes patients. In a diabetes encounter, if many of my patients are also a chronic pain patient, we do not create a churn, or I would not have a patient come back who would see me on a Friday for diabetes, come back on a Monday or Tuesday for their chronic pain visit. I take care of the chronic pain encounter as well within my diabetes encounter. We do the same thing for coag. Our physician assistant who sees the AFib patient won't just see them for AFib. They'll take care of, anything from the common cold during that encounter to making sure that prompting for our diabetes programs are addressed as well. So we don't take care of the patient in isolation when it comes to these disease states. It's a holistic approach.
Great, thank you. Jennifer, are you able to see some of the questions now? Or
yeah, I'm seeing them now. Thank you.
Okay, thank you.
So there's one. You want to read that question then?
This one or this one?
That one. Yeah.
Okay, so the first one we received, do you plan to automate your clinical protocols, and in PS, can you discuss challenges and successes of that process?
So the protocols have been automated to a great degree, and that's the decision support that I just mentioned in some of the slides. So what we put on paper, we have integrated into registries and prompting. All that is coded into what you would see on the visit planner, the paper document that drives the care. So the idea would be is that we had to come up with a system that required minimal training for this large staff, these part-time providers who are largely residents. So that's what we had to do, was to hardwire, hard code our algorithms that we came up with through consensus into the paper document that's generated, prompts that are generated, and the care that we want delivered by care assistants and other staff.
We have another question on what behavioral interventions do you utilize?
That's a good question. This is actually the program I'm most excited about right now, and something that I think we are doing great work in. What we have is a social worker on staff who's coupled with one of our care assistants, and we follow what's called the impact care model. I think it's out of, and don't quote me on this, but it's Michigan or Minnesota or somewhere, but it's a great program that really focuses on action-oriented interventions and problem solving for patients with depression and anxiety. We've been really pleased with our program to date and the outcomes we're seeing. Patients are pleased, providers are pleased. We've seen benefits that we didn't expect, like improved flow through the routine visits in our primary care practice. We have identified gaps where we had to really think on our feet. Suicidality assessments, policies regarding sending people to the ED. We've identified gaps where we could really use assistance of a psychiatrist for some really complex patients. So we've done some great work. There's more to do, but we're very pleased today.
We have a few questions about the care assistant roles. One about, sounds like there would be turnover, and is it correct that they're responsible for approximately 1,200 to 1,300 patients, and how is that ratio working?
Yeah, so the slide, you picked up on an important point, and that's where the volume and encounters are dictated by our stratification algorithms. So what we're trying to do is to use our data to push patients who are at most risk for failure to care assistants. There's no way they can care for 1,200 patients. There are about 200 patients that are really under intensive management at any one time. That is what is limited right now just by our resources. We would love to provide this care for all 1,200 patients, but we just simply cannot do that right now. That would be something I envision right now, that we really do deliver high-quality, efficient care to high-risk patients at risk for failure. We can, about 1/3 of our patient population is managed in that manner. The other 2/3, we simply don't have the staff to deliver this intense intervention to. The turnover is an issue, but it's also one of the better qualities of the program, I think. What we do is an academic year, care assistants sign up for 1 or 2 year stints with us. We've never had one leave us early in 10 years, well, 8 years of doing the care assistant role. And it's because they're here until they get into medical school or they get into a PA program. So we know that we usually have an overlap. So we have a train-the-trainer mentality. It takes about 12 weeks to train the care assistants to get them up to their to be proficient. They're not expected to be healthcare providers. They're really just talk to the patient in plain language, figure out what the problem is, and find a person to solve the problem for you. So when I'm in clinic seeing my diabetes patients, I'll probably answer 6 or 8 questions about patient contacts that care assistants are having, and we'll decide together what to do with them. But it's usually care assistants cannot function without the primary care provider's engagement.
And one final thing about their training, someone asked if motivational interviewing was a technique that they're trained in?
A couple of years ago, I would have said yes. And I say that because we have hired, or have now, a dietitian who is, I would classify her as a motivational interviewing expert, and she's not happy to the level of what they're doing, and is actually revising training, and that is actually a focus of their training right now. So I would have answered that yes a few years ago. Now I would say we're okay.
We also had a question about what EHR we're on.
UNC's electronic health record is a product that was homegrown. It's called WebSys. It's been developed here, recently sold to Siemens, who is prepping it for release to large academic centers. Our homegrown registries are access-based that use data that are within a warehouse that is supported by our electronic medical record.
And a question about how many patients you see a day and what your volumes are like.
What our volumes are like. Our goal is, well, that would vary between which year you are in your training and if you're a faculty member or not. Our busiest or our most full-time provider sees patients 5 half-days per week. He's probably one of the most efficient providers in our healthcare system. Unfortunately, I can't quote the numbers for you. Our 1 half-day per week faculty physician averages 10 patients per half-day session. I don't know if that's the information that was desired, but that's our target right now. That's for routine visits, new patients, not just these chronically ill patients. These patients, chronically ill patients, would be scattered within that average number of 10.
I also had a question early on about how did leadership train and orient the care team to work in the PCMH model, and we had an interesting experience with that the other day where I spoke with one of the nurses about how it was to work in a PCMH, and she didn't actually know what it was, but when she described the work she did, everything she did is PCMH. And so my experience at the internal medicine clinic was that they were doing so much of this work before we applied for recognition that it's just how they do what they do. They don't see it as a program or an initiative, but the type of care they provide is exactly in line with the joint principles of PCMH.
Yeah, I think that's a great point. And PCMH was not on our radar screen until 2.5 years ago. We were delivering the care that fit the model. We just didn't call it that. So Jennifer's exactly right.
And we also had a question about residents, and I'm sorry, I'm trying to find, there's a lot of questions have come in, and I'm trying to consolidate them.
Well, while you look, let me talk about residents.
Yeah, talk about residents.
So residents are an important focus of our program. So early on, there was a concern. What if we do this so well that our doctors don't know how to practice or take care of a patient with diabetes? I'll tell you that through various mechanisms, we have disproven that, in that, number one, our providers already provided great care. It was just not what to the degree we wanted to see it. We evaluate our residents' learning. We make sure they still see patients. So, for example, if a diabetes patient is in our program, the resident is not removed from that, or the primary care provider is not removed from that. They're just made a member of the team. The team functions around that primary care provider. And so no visits are taken away. In fact, more patients are kept within our clinic. We see fewer referrals out to specialists because of this. So we would argue that you actually have more care that is supported by a team that is expert in the care of those patients, and the training is better. And we also have rotations for interns and third years. These are electives. Every month we have 2 or 3 residents rotating through our programs and learning quality improvement and chronic illness care principles.
I know we're about to run out of time, so Guy, I was wondering, can I preserve these questions and maybe we can send something out to the group?
Yeah, I'm sorry, this is Guy. All the questions will be captured, so we'll be able to assemble those and work with Jennifer and Rob to get those answered for everyone.
It looks like we have about 3 more minutes. Are there any other questions on that?
One of the questions about residents was continuity for patients.
Oh, yeah.
Can you address that?
Our continuity rate, we do assess that. We did do that as part of our PTMH application, and that's been one of our principles, is that we're really focused on continuity. The interesting thing is there's a perception that continuity is a problem. If you ask one of our residents, they would say it's difficult to do. I oftentimes see patients that are not my own. That's true. They do, but what we know is through our data that 80% of the time a patient sees their self-identified primary care provider of choice. So our continuity rate is actually high in our resident practice. What we feel like is happening is that it's just when that 2 out of 10 patients they may see that half day in their third year are not theirs, they obviously create a lot more strain and stress and more work at that visit. But 80% of the time was, I believe, was the number in our application that we came up with.
Higher.
And we do monitor that on an ongoing basis because that is one of the fundamental principles of our practice.
And the attending continuity was at like 98%.
Yeah, attending was like
crazy.
Yeah.
And there's a question also about how we interact with specialists outside the practice, and if you've done any work on that. And I did want to mention that they do have 2 dedicated referral coordinators who do nothing but that. One works with the specialty clinic, and one works with the ancillaries. And they, because they're dedicated to it, develop relationships. And I think that that's helped a bit.
Yeah, and we our endocrinology practice is diabetes recognized, and they have a care assistant within their practice as well, and they use our registries and a visit planner type process. Cardiology, we've done similar things in. So we are spreading the model around, and there's great interest here in creating a pool of these employees to do this type of work in various practices, including specialties.
And finally, someone asked how we make sure that this work is sustainable. And there isn't much time for it, but CQI in this clinic is huge. Continuous quality improvement is something that you work on regularly. And I don't know if you want to speak.
We maintain a tight budget. We have some funding to do this, not as much as we used to. So we feel like with the model we have now is sustainable through encounters, charges, our outside funding that we do get. So we feel like 11 or 12 years down the road, that does show some sustainability. This is not research anymore. That's all of our questions.
Well.
Or